gonna move this because I just worry I'm gonna like spill grape seltzer water all over the computer. So good afternoon, everybody. Really glad to be here to talk with you about integrating social determinants of health into biostatistics research and practice. And I just want to start by acknowledging the members of my research team who are here in the front and second row. They play an invaluable part of the work that I do. So I'm gonna talk about my own work, my own research. So, and just as by a way of background, I am trained as a psychologist and I do basic behavioral science research in minority health and health disparities. And being here today makes me think back to many years ago when I finished my doctorate. I thought about doing a master's in biostatistics, but the thought of being in a classroom just again made me want to vomit. So like, not for me, but have really enjoyed the growth and evolution, I think, of the biostatistics field. So I started my career at the University of Pennsylvania, which was really a great opportunity to work collaboratively with a tremendous group of biostatisticians and epidemiologists. And one of the things that was really critical for me and has continued to be a focus of my research is minority health and health disparities. So as you can see here, this is the most recent definition of disparities. And, I'd like for this I know we typically do these kinds of talks where, you do your talk and then you kind of have questions, but please, ask questions along the way so that it's more interactive. But one of the things that, and I'll ask you questions of the audience because to help facilitate that process. But as you can see here, disparities are really just differences. And I think at its crux, really brings in some basic statistical processes because you're trying to understand the ways in which groups differ in terms of health risk and outcomes that are linked with social, economic, and environmental disadvantage. So these are kind of the main components of our department. But what I want to draw your attention to is that, in the very beginning phase of minority health and health disparities research, we really focused on race and ethnicity as the primary way in which we were trying to understand differences in disease risk and outcomes. But as you can see here, the variables that are of interest for us from a disparities perspective has really grown. It includes religion, socioeconomic status, gender, age, disability, gender identity, as well as geographic location. So our definition of health disparities has become more inclusive over time, which I think is really important because it allows all of us who have interest in health and well-being to be engaged in this enterprise, in this research area from all different vantage points.
Can I ask you
Sure.
a question? So, for example, we all know that most health risks go up with age. Mm-hmm. So age is just a fundamental risk factor. Mm-hmm. So by putting age on this list, are you just pointing that out, or are you saying additional health impacts just because of lack of access to care when you get older or biases or something?
That's a great question. So I would think about age as being the quality of one's lifespan. And so if you think about now for health disparities research in particular, where there's a greater understanding, for instance, of adverse childhood experiences or ACEs, which can then have sort of long-term effects in terms of adult disease risk and outcomes. So age, is considered for that reason, but there's also ageism and just, as another sort of manifestation of the ways in which age can influence.
And age and exposure effects.
Age is absolutely. So you're bringing a very biostatistical approach.
Sorry.
Which is awesome. But, so again, so this is where like team science, transdisciplinary science comes into place, because as a behavioral scientist, I would think certainly from the risk exposure perspective for sure is like a biostatistical epidemiology framework. But here is sort of like adverse child experiences, the quality of the aging process and how that differs across groups. I think the other thing that's relevant for the discussion here today is that these variables don't operate in isolation. So if you think about intersectionality as one of the components that I think is a really interesting and intriguing thing for that biostatistical expertise can really be brought to bear, is how do all of these different identities influence disease risk and outcomes. So for someone like myself, built to have my focus has been really on race and ethnicity, but now we're thinking about all the different ways in which our identities can intersect and influence exposure, risk, and then outcomes. So related to that, the other concept that I want to talk about and introduce you to is how we think about these variables within the context of social environment, one's lived experience. So this is a model, a framework that was, it's probably kind of dated now, but, it was insightful at the time that it was developed, I guess in the early 2000s, mid 2000s, because it moved us away from thinking about individual sort of different levels of influence. So again, you all know as biostatisticians, you're trained, you're in school for biostatistics, you'll go on and have a career as a biostatistician in other areas. That same process happens across all disciplines. So as a behavioral scientist, I did health behavior research, and my kind of bucket is, I don't think this has a pointer, but my little bucket of research is like here, health behaviors and coping strategies. But what this framework really has introduced us to is the importance of working across levels of influence. So we can't just think about minority health and health disparities from the perspective of like individual health behaviors and coping strategies, but recognizing that those domains, what we do with respect to screening, diet, physical activity, other health behaviors, all take place within a broader context. And that sort of was reflected by the levels of influence as well as the domains of influence. So here we are now in 2024, where we're all talking and really interested in social determinants of health, which at its crux, its foundation, really is focused on understanding the ways in which where and how we live influences disease risk and outcomes. I'll draw your attention to a couple of things that I think is interesting in this figure, because one of which is that, it recognizes that clinical care is important, health behaviors are important, but if we think about, if we disaggregate sort of the contribution of variables, the 50%, is due to, your zip code. And that's sort of reflected in your social and economic factors of status, the physical environment in which you live. And then there's like 30% due to health behaviors. And then the remaining are due to, issues related to healthcare and access to healthcare. So what this has done is it really sort of gives, I think, space to, to be, I think, inclusive again, but really think about the social environment as a primary driver of disease risk. And in this context, I'm showing you cancer health disparities because I do cancer research. So I wanted to share a couple of examples of how, these sort of issues, these social factors are now being addressed, understood, and ultimately intervened on as part of a cancer research program. And this is an example of a series of commentaries that looked at food insecurity, housing insecurity, and transportation insecurity. And all of those things are kind of done at the level of individual sort of self-reported information, but because of the influence of biostatistical methods, we now have the ability to look at them not at both the individual level, sort of what you self-report, what a patient reports in terms of their ability to access food, have secure housing, access transportation, at multiple levels. And I'll share with you some of the work that my team has done and others to kind of integrate this sort of multiple level use in sort of, which really builds upon some basic statistical principles. Well, not basic, they're advanced. I'm going to just say it. I mean, it's not something I could do myself. It's more than a t-test. I should have titled my talk "More Than a T-Test." So, you know, one thing I think is really interesting, this is why I was interested in biostatistics, you know, earlier in my life. I mean, because it really permeates all of the things that we do across all research areas. So study design, data collection and analysis, as well as interpretation of results. And I think one of the things that I have grown to appreciate is that you know, it's really important to engage our biostatistician colleagues in all of these phases from very early on. And there are ways to incorporate social determinants of health into each one of these aspects. So if we think about the research question that we're being asked, we can think about, do we want to compare two different racial or ethnic groups? Do we want to look at within group heterogeneity, which has implications for the study design, the data collection and analysis, as well as the results interpretation? And what I'm going to do now is transition to some of the examples from my own work, but to sort of set the stage for that, what I want to do is sort of share with you a model that I think is really important because it illustrates all of the different ways in which biostatistics can be social determinants of health can be integrated into biostatistics research and practice. So this framework was developed, the authors here are all, one's a social worker, they're all sort of, one is I think a behavioral scientist, and then the other is I think a clinician, a nurse, or she might be an epidemiologist. I don't know what Dr. Geronimus is, what her background is. But basically what they've done is sort of taken this idea, this hypothesis about the contribution of the sort of the ways in which the social political structures or the social environment, social determinants of health, drawing a framework, a model, and illustrating some pathways, mechanisms through which that ultimately leads to racial differences in breast cancer subtypes. So if you think about, you know, how we would go about addressing this within a research paradigm, you know, biostatistics plays a really important role, starting from the very beginning with how do we measure with reliability the social political structures? How do we do that? How do we analyze those data? Because the data are coming from census level data, if we were doing this as part of a survey design, you know, I've done some work with the nationally representative samples. Biostatistics plays a really important role in defining like the sampling strategy, analyzing the data, weighting the data. I think I wanted to poke my eyes out literally when you know, it was my first time working with data. And it was like applying like a weighting to the data. I was like, okay, I give up. I yield. But all of that to say is that, you know, there's an important role that biostatistics play in this. And so, you know, we can integrate, and if you think about how you might operationalize this framework within a research design. So what we want to compare, if our outcome is in this case, disparities, a disparities outcome, is the right comparator, Black and white women with breast cancer? How will we analyze those data? What's the appropriate study design? So that's kind of what I want to set the stage for. We're doing this work. This is a book that I edited where you can read more about the work that's being done from, you know, really focusing on in this work from understanding these determinants, and includes a chapter on social determinants and cancer health disparities, all the way out to interventions, which ultimately what we want to do. So now I want to transition to any questions about, before I talk about more, any questions about anything that I've shared thus far? Okay, so I mentioned that I'm a behavioral scientist. I've really been focusing over the past few years on basic behavioral science research, which is really trying to understand the ways in which sort of our physiological responses to stress and the stress reactivity process influences cancer control behaviors among diverse populations. So this is a model that I'm sharing with you because it illustrates a couple of key points. One is that we think about minority health and health equity from its very early stages. While there's a focus on social determinants of health, that's the language and the terminology that we're using at the moment. This has been a focus in minority health and health equity research for many years. So this model was published in 2013, but it really illustrates sort of the role that social characteristics, which you can you'll remember from the slide that I demonstrated about social determinants of health, are really the social determinants of health shown here. That can lead to difference to stress exposures, which ultimately influence physical, mental, and general health outcomes. So all of the things, social resources, personal resources, are more within the psychology area. Dr. Turner is a psychologist, and so the goal here again is sort of taking more of an individual perspective. But think about how we would understand that from a census level, using more geographically oriented data and the biostatistical expertise that would be needed to create a variable or a series of variables that could represent the contribution of the lived experience in a model such as this. Any ideas, thoughts? Anyone doing this?
Maybe this is a little bit off topic, but the original design of the case control studies that were conducted here was to go to do neighborhood walks and try to adjust for all sorts of these variables. I mean,
that's not off topic. That's exactly what I'm talking about. Yeah, so great example.
I think that approach has been largely, well, it's with a big cohort like the multi-ethnic.
Right. So, you have to think about the scale. So I think if you were going to do that approach, now what we would call it is something like photo voice, which is more of a qualitative approach where you have people talk about and reflect their lived experiences through photographs. And then that kind of tells the story. But what you described is really insightful. I've not heard of that approach. Any other thoughts? I think you had a comment.
Yeah, I was wondering, for a GIS model, are you trying to make an inference on an individual in the context, or are you trying to make inference on a context on an individual?
The second thing that you said, but also both. So let me share with you some examples and then we'll come back to that question, because I think I understand the difference. The math, the statistics part is right here, but that's an interesting question. So this is sort of what my own studies are doing. We have an ongoing study now where we're doing a stress reactivity study here at USC among Black and white male smokers. As an example of the first bullet, the other aim within a previous study that I'll share with you about is looking at the ways in which the social environment influences how African-American breast cancer patients respond to an acute laboratory-based stressor. And then also within our ongoing research, we're really trying to make the connection between differences in stress responses between Black and white male smokers, how that might account for differences, racial differences in smoking behaviors and ultimately lung cancer outcomes. So just to share with you, I mean, one of the things that I think is really important to recognize for the students in the room that, we all sort of, build upon an existing research base. And, my interest in stress reactivity really came about through this study here, this animal study, where the investigators did this really, at the time, innovative experiment where they It was a social isolation study. They used that design where they had rats that were, one group of rats were like socially isolated. So the little rats were living in their cages, by themselves. They couldn't interact with one another. And then in the other group, the rats could interact. And so what they found was that social isolation, leads to a dysregulation of the endocrine system that ultimately results in the socially isolated rats being more likely to develop mammary tumors that were bigger, and also that were more histologically similar to those that develop among African American women. So, one thing I'll just point out is, a statistician played a role in determining how many rats needed to be in the study, what the randomization scheme was, did the analysis. So really important what I'll draw your attention to is this is a way of taking sort of a social construct, a social determinant of health, and replicating that, addressing that within a laboratory setting where we had to have sort of the multiple types of expertise, and the biostatistics played a huge role in sort of creating the study and allowing the investigators to do it with rigor. So what do we do? So one of the things that we sort of thought about was that in our own work, people don't live in like the physical cages in the same way that animals do. And so we were interested in sort of taking this concept of social isolation, a social issue, and replicating it in a laboratory setting. And so this was our first study that we did with using the TSST model. So the TSST stands for Trier Social Stress Test. And what it does is it's a procedure where individuals come into a laboratory setting, they're given two tasks. One is like a speech task and one is a math task. They're asked to do this, and there are confederates in the room who then sort of say, that's wrong after a certain point. And it really does activate like the HPA axis stress response. And so we're able to sort of understand like the cortisol changes that occur during that stressful activity. It's a well-validated laboratory method of activating an acute stress response reactivity. And so the goal for this study is, which we have completed. This was done, the data were collected at my previous institution. But what we were interested in is, one, the first aim is like understanding stress reactivity in a sample of African American breast cancer patients. So why would we want to focus on African American breast cancer patients and not do a comparative study? Study design issues. So this is where the biostatistician sort of gave us some guidance and direction. Thoughts about that? Why would we want to do it? So R21. So lots of different lessons here to sort of draw out. R21 is a small study. It's like I think we had 2 years of funding.
Sorry, could you restate your question?
Sure. So the question is, why would we do a study in this method if we're interested in disparities? So, and typically disparities, like you compare one group to the other. But in this design, we only included African American women with breast cancer.
Well, was it already well known that African American women have different treatment compliance than other racial ethnic groups?
There you go. Okay, absolutely. So in order to sort of maximize, our statistical power and our resources that are available in the grant, we already know that racial disparities between Black and white women are well established. So our question is really about, well, what are the responses and the reactivity within groups? So within group heterogeneity is what we were really interested in understanding based on women's self-reported socials, like lived experiences. So we have a social determinant survey that we have used in every single study, I think, continue to use it. And so we were interested in understanding sort of within group heterogeneity, within stress responses based on stress exposure. I'm like, how many times can I say stress in one sentence? Is kind of what I'm thinking about now. But then we also put it within this broader sort of this mediation model where we were interested in the ways in which stress exposure might influence the ways in which individuals sort of prioritize sort of immediate versus future consequences. So this concept of temporal discounting. And we hypothesized that women, as they're making, as they are having an acute stressor, they would, be be more willing to make like a decision under stress. So have you guys ever made a decision when you're stressed out? Have they tended to be good ones? So that's kind of what we were wanting to get to here. And then treatment compliance was our final outcome. So you can see a couple of ways in which, so the overall design was one around social determinants of health, but we really had to engage our statistical experts to kind of help us sort of draw with this mediation model. And then, in our grant application, one of the reasons why I think we were successful is because we really were able, although this was an exploratory study, we didn't have preliminary data of our own. We made the case, based on other previously published literature to help us determine what our sample size was, so power analysis, and then develop the analytical strategy. So this is just giving you sort of what we accomplished. Unfortunately, this work was done, was impacted by COVID-19. So we had a final enrollment of 120 women. That was our sample size. We were 10 women short in terms of our study enrollment. And you can see where the three different sort of study things that women had to do as part of doing the study design. So let's talk about the data analysis. So, we've done some preliminary analyses that as you can see here, which, not the teeth test, the chi-square test or the Fisher's exact test is like my capacity. But what is, and this is all fine and good, but what we're able to do now with Jun Han, he's done this amazing work to really disaggregate sort of the stress reactivity, looking at the individual variability. And I'm not going to show this data because this is what Fatimata's working on now, so I wasn't going to scoop her. Next journal club. But, she's taken like this, my sort of, logistic regression, again, my level of expertise, and really done some really important analyses to help understand like the within group variability and then between group differences based on social economic characteristics with social determinants of health rather within this particular population.
So, sorry, just to get a better idea of this, if you go back to your figure of the mediation, right, because the mediation triangle that you showed is really that behavioral part of your table over there.
Right.
Cortisol is maybe the biological representation of that part.
Yes.
So is the idea, I guess, in general, one would be sort of baseline levels of cortisol and stratify maybe the mediation by that?
Yes.
Or who changes the most?
So
cortisol levels or something.
So it's both. So we're actually who changes the most, but this temporal discounting. So this figure doesn't reflect that there was a randomized trial as part of it. So women were randomized to get the temporal discounting task either immediately after the TSST or which meant like 10 minutes or 20 minutes afterwards, sort of looking at sort of the short and long term as like the randomization variable. Because you can think about, so like if you want to understand like the world that stress might impact on this temporal discounting, you can like making it like, so if I were to make a decision like right after I leave this room, I can still be a little stressed about being up here talking. May or may not be the best decision that I might make over the course of the day. But so you're
so the stress is the same. It's the
there's a
trial is on the temporal disparity.
Right.
Okay.
Right. So why did the question might be, why did I present this? This was part of, what we had to present at our Science of Behavior Change meeting. So, but thank you for bringing that point out. So the next example that I want to give is from our, yes.
Yeah, sorry, please. You mentioned you did this social determinants survey at baseline. Can you maybe?
I'm going to tell exactly what it is in
Okay.
2 slides.
Okay, thank you.
So the next example that I want to give is from a precision medicine center that focuses on precision medicine and minority men's health. So a couple of things that I'll draw your attention to. One, this was a multi-regional consortium that included sites in Philadelphia, Texas, and Virginia, as well as South Carolina, and now California. We were focused on doing translational research that really designed to tease apart sort of these multi-level drivers across multiple domains, so biological, social, psychological, and clinical factors. There was a dissemination and integration component of the center, which was really designed to translate our findings and intervention approaches that were to be developed through the center's work out into community and clinical settings. And then there was a data integration core that focused on developing tools and resources that could be leveraged, used, and applied in clinical settings and it ultimately grew into a core that really focused on using artificial intelligence and machine learning approaches to identify social risk factors, social determinants of health using the EHR data. So who was at the table for this work? You can see here we had a variety of individuals. Myself, in addition to I'm a geriatrician at the University of Pennsylvania, a radiation oncologist, a geneticist, and a urologist. It sounds like the beginning of a bad joke. But our focus for minority men's health was because we had been doing a series of studies that focused on understanding, again, racial differences and quality of life among Black and white men with prostate cancer. And we continue to focus on that because one of the things we learned in each of these different vignettes or studies that are published here is that some aspect of stress and stress responses was important to men's quality of life, important to how men reacted to their diagnosis. Also at the time, I was living in South Carolina, and there was unfortunately an example where an African-American man was shot in the back by the police. And so, one of the things we started asking questions about was how does the broad lived experience of Black men influence their sort of disease process and risk outcomes? So it's it was an innovative way of integrating the social context, the social issues at the moment into the fundamental premise and goal of the study, which is really to sort of understand the ways in which minority men experience specific stressors in their lived experience. We also know this built upon and integrated the data from the animal studies, which showed that there's a biological consequence of having stress exposure. We were interested in using allostatic load as a way to characterize the physiological consequence of chronic stress exposure. And this is not anything new because there are several studies have examined racial disparities in allostatic load. But what we don't have and what we've sort of been focused on now is that there really isn't a huge body of work that has really helped us to understand the ways in which allostatic load influences disease processes and outcomes. Part of it is a measurement issue. So part of the challenge is that, when you look at, how many of you have heard of allostatic load? Oh, well, that's awesome. More than I thought. So if you read one paper on allostatic load, you've read one paper on allostatic load, meaning that the ways in which the biomarkers that are used to compute and determine allostatic load are really specific to that study. and the way the papers will go, if you guys can remember, you can correct me if where I'm wrong, is that allostatic load is typically you can derive using 12 biomarkers. We had this data available to us. This is our measure of allostatic load. So it is rare, and even in our own work where we had like and I say I'm citing exactly what we said in a paper that was published several years ago. But what we've been trying to do at this point is sort of create a standardized abbreviated version of allostatic load. And our first sort of entree into this space was doing a factor analysis. We did a confirmatory factor analysis and looking at all the biomarkers. That fell flat because I was left to do it. I did it. That was what I did my dissertation on. And so a word to the wise, when you finish your dissertation, leave it alone. Go on to something else. In terms of methodology, so, I think it's, and I can explain that later. Dave and Jim might have other thoughts about that statement, but what I want to draw your attention to is that, there's a big measurement issue in allostatic load that we need to address. And this is one of the areas where I think, statistical input and expertise would be really valuable. This is kind of the ultimate goal of each of the 3 studies that were included in the project. And this is our social determinant survey. So we have published this, and I don't have the citation here, but we published a paper that describes our lessons learned, and it describes this survey in greater detail and the rationale for the components that we included. But what I want to draw your attention to is that, well before we were talking about social determinants of health, we were thinking about these sort of socioeconomic factors, and particularly low income, not having consistent employment, having few years of formal education, being unmarried, financial toxicity, financial strain, and sort of this bucket of social economic stressors. Because we were doing work within men, at various stages of prostate cancer risk. We also included disease-related stressors. And then as part of our social determinants of health survey. And then finally, we asked men about their perceptions of stress and social isolation. Again, sort of including some of the variables that were important to animal studies, important to psychosocial and behavioral studies within our battery. So the first example that I want to share with you is from our data integration core, because this brought together expertise in population and behavioral sciences. And when the population sciences, I would include our biostatisticians in that sort of category, because what we were able to do is sort of identify what the social determinants of health that are most important to identify and extract from the electronic health record, and then to give some examples of how these domains are likely to be represented in the electronic health record and the clinical narratives. And then we have machine learning and informatics expertise who actually developed the algorithms, created the tools. And this was at the very beginning stages of where GIS, geospatial information systems analyses were being used to understand and represent the social environment within using a quantitative measure. So the example that I want to share with you sort of focuses on social connections. And, this is to show you that we did create a pipeline, and really our informaticians and machine learning experts were the ones who really created this pipeline, where they extracted the clinical notes from the institution had a research data warehouse, which was an exact copy of the actual live Epic data warehouse. They used that to create a training set and a test set, and then they applied the algorithms, and using that data and sort of came out is magic with precision, recall, and F-score. So a lot of very complex biostatistical, processes were at play in this one example. We published this work and have gone on to really, with subsequent funding in the VA, which has some of the most robust data sets, I think, that exist within a healthcare system, to really delve down deeper to understand the generalizability of the algorithms, and also to develop tools that can actually be used in a clinical context. So the last example that I want to share is what we've sort of, again, I mentioned we were sort of at the early stages of using GIS methods, and this was my former postdoc, who is now a psychiatrist in South Carolina, focused his time on sort of learning how to develop and use GIS as part of a cancer control research program. But again, I really feel like, GIS is really a lot of statistical methodology, because you have to take the census data, make it into a way that can be combined into a cumulative score that reflects a social deprivation index in this example. So what do we do with it? I mean, so, how we use this work is a couple of ways. One, we've now incorporated it in a standard way across all of our studies, so that we're able to at least have the raw data that can be combined and aggregated into the social deprivation index. But then the other thing is, like, that's what I'm showing here as examples of how we use the instrument. I think is really preliminary. And so, because we sort of said, you're high, low, high, medium, or low in terms of social deprivation, but they're more complicated, more complex statistical methods that we have not even begun to scratch and begun to address using this sort of multi-level information. And so here, what I've been really excited to do is work with Dave, Miles Cockburn, and others on sort of using this hotspot methodology, which is really like, I think some of the most sophisticated statistical work I've ever seen, where it's like trying to understand like where and how groups reside and how that matches with cancer hotspots. So and this is an example of using, I think, lung cancer data and sort of characterizing where there's like high and low relative to like the space of healthcare centers, community hospitals, and academic medical centers. So the way this matters is influential to me is that it sets the stage for how we can activate our recruitment methods in areas that we know are hotspots if we're wanting to target people for lung cancer risk, lung cancer prevention. It helps us understand from a high organizational level about where and how we need to prioritize our resources as a cancer center and as those of us in the department who are interested in making inroads. I think in the interest of time, I'm going to stop there. I think we go into one, right? I want to allow a few more minutes for questions. Thank you. Yeah. If you're interested, my final comments, if you're interested in learning more about social determinants of health, I'll draw your attention to a recent workshop that was created and conducted through the National Academies. I had the privilege of co-chairing this workshop, which was focused on examining the interactions between biological variables and social determinants of health. Our planning committee was very diverse from a background and discipline training. We had clinicians, geneticists, statisticians. It was very comprehensive. So the proceedings will be available shortly, and the workshop is posted on the National Academy's website. So thank you very much.
How far along is the work with the cortisol?
Well, so.
All published now?
Fatimata, do you want to take that question?
Sure. I'm actually writing a manuscript on that right now as we're speaking. And the first aid that Chanita described, understanding distress reactivity in African American breast cancer survivors and seeing if there's any differences in stress reactivity depending on social stressors that they may be exposed to. And what we did find is that all women who went through the Trier social stress test, if you stratify, they're all breast cancer survivors. If you stratify by having high or low perceived stress, high or low financial strain, or a high or low negative life event, consistently those who have the highs in these social risk factors had significantly higher cortisol response compared to those who did not. And so that's one of the, I think, really major findings, to see some differences, in terms of stress reactivity, just by social risk factors, modifiable risk factors, and the implications for cancer treatment outcomes.
Yeah, it sounded like very interesting work.
It's really fascinating. Yes. I was typing and I had to stop to come here. Like, this is so good. Where should I send this? What journal? Anyone? Any recommendations?
Did I answer your question about the social determinants survey?
Yeah, I guess I'm just curious, if that specific survey was piloted, we've used a PSS, perceived stress score, to evaluate, for example, stress during the COVID-19 pandemic and access to health for patients. I'm just curious if that was piloted, because the issue we've been having with that scale is that it's like a double-edged sword, right? Because it can be very broad, and you're gonna capture this alphabetic growth by stress that's coming from different factors, but then you can also make it very, very specific and very narrow. Depending on how you ask the question, you can be referring to specific stressor that patient may be, or the participant may be going through. So I'm just curious how that.
Yes, so we did not pilot the survey, and the components of the survey before we did the work, and we can be criticized for that. But I'll also say that the PSS in particular is a well-validated survey that's been used in a variety of different contexts. We would share your sort of what we see similar trends, which is kind of an opportunity, right? So we can think about, I'm interested in psychometrics. And so the question is, if you see kind of PSS was developed in the 1970s.
Yeah.
And so is it time now to, think about a new type of instrument, and what can we glean from existing data to help us think about sort of creating a new scale? So for those of you who and psychometric is really active, involves biostatistics from the perspective of there's a sequence and a methodology to new instrument development and validation. So we published that a couple of scales doing this, a psychometric approach, where we did focus groups, qualitative interviews to kind of understand the domain of interest. We did like a initial validation survey within like a hospital sample. In this case, we were interested in attitudes about genetic testing, I think is how I might broadly define it. And then we did a nationally representative longitudinal survey that had baseline and then a follow-up to do retest reliability, and also to do a confirmatory factor analysis. So I never left my dissertation work, even though I would say, but your point, I think, is well taken, that, there are, if we think about some of the social determinants instruments, there's now the PHENX, which is a module that was developed by the National Institute on Minority Health and Health Disparities. They have a huge battery of instruments that you can use or consider using as part of your research program. So the PSS, I think, is included in the social determinants module. But I think we've, and Fatimata knows, has some experience that she might want to share too, but we haven't seen kind of robust associations between our PSS measure and things we would expect for it to be associated with.
Yeah.
So I think it's just a critique about, stress. I mean, 1979 stressors are different from 2024 stressors. Did you want to add anything?
No, I think, yes, I will just second that, and, the PSS, as you said, was developed way back then, and it's not as highly sensitive to physiological measures of stress as we assume or we imagine, and it really begs the question to, is it time to maybe think about developing instruments that capture, physiological, psychological stress that, would be sensitive to physiological stress outcomes. That's a huge, we can talk about it after this.
So let's come back to your question, because I'm not sure that I addressed it, but the way in which we used social deprivation as like an indicator of the broader social environment. So in this case, it's really reflective of, I would say we sort of looked at between group differences using that as the outcome variable, but certainly they're more sophisticated, true multi-level analyses that can be done. And so we have not done that with this data set. For those of you who are interested in this data set, let us know because it's available.
So I have a question going back maybe to your first slide, and you talked about sort of, historically looking at health disparities, and the first bullet point we had was race and ethnicity. And, it becomes a variable, self-identified. We measure it by people filling out, some bubble, and that becomes the variable. So I guess my question is your thoughts on the usefulness of that as a variable, because we know at some level captured captures other things. At another level, it is in of itself a representation of that experience, right? And, putting this in the context, because now the National Academies report that just came out on population descriptors, geneticists are very quick to say, well, genetic similarity is a continuum. And that's true from the genetics point of view, but substituting that variable into this context doesn't necessarily, help us in some sense. And, and trying to figure out how those two worlds come together, I think.
Yes. So thank you for raising that. I actually reviewed that report and had a lot of questions.
Yeah.
About what do you really want this report to do? I mean, and I would encourage all of you to check it out, because it does describe sort of the value and the how we use self-identified race and ethnicity in epidemiological research, behavioral science research, genetics research. And so, the tenor of the report, if I remember correctly, was like, we need to move away from self-identified race and instead, depending on the question, use genetic ancestry as like the variable that helps us understand race and ethnicity. So I think that's an interesting point, and I understand the reason, but I think self-identified race is important to still capture because it reflects one's lived experience. And so if you do like the genetic ancestry analyses and you kind of, you can show a lot of different things, and then it's like, well, have you lived your life that way? And so I think that's the main sort of issue that I would say within the broader context that we would go into genetic ancestry. I think without including self-identified race, we would lose something really important and powerful that helps us understand how people live their actual lives. I think there's a place for genetic ancestry work.
Great answer, because I think, that report was great to bring it to the surface, but I'm wondering if it caused more confusion than help in this.
Well, thank you for saying that. That was my whole take home point for the review. I was like, what do you want us to do?
Yeah. Yes. Okay.
So for differences though across populations, let's say by self-reported race, ethnicity, the variable will add unique information, even if you consider like other risk factors. Let's say you're looking for differences in risk of cancer across populations, and you consider type 2 diabetes prevalence, BMI, right? And then ideally, when you start considering those variables, the risk starts to get more and more similar between groups. But are you saying that you think there is always unique information by self-reported race ethnicity, and you could never fully get those distributions to overlap? Or are you saying it's just too hard to get that? Because, for the EPI studies, for a lot of what we do, we're dealing with big data sets. So for a lot of these social variables, it's very ecological. Like it's very, to me, it's very high level and crude, like neighborhood socioeconomics, like a whole neighborhood, so.
Yeah, so I don't think the reason for the second thing that you said is not, I don't think we should make a decision based on whether or not something is hard or difficult. I think that there is some information about self-identified race that's important to include in addition to the other sort of variables of interest. I think that, and that is, so I don't think I have more different, I would say the same thing, but it really makes me more confirmed in what I'm thinking, which is that, the way in which you live your life, I think is really important. And race, ethnicity, in my view, is a social construct. You don't want to confound it as like a biological variable, because it's really the way it's manifested here in the United States. It's a social construct that, in my opinion.
My impression is, at least with sample sizes that I'm familiar with, which is, in the multi-ethnic cohort study, that it's actually quite difficult to tell the difference between the effect on the outcome of self-reported race and genetic ancestry.
Okay.
But I think that gets to your point specifically, is this recommendation to include genetic similarity ancestry as a variable pushes it towards a biological interpretation, even though it's capturing non-genetic effects, right? Because it's more highly correlated with it. And so it almost makes the situation worse. Instead of just, here's variable that was self-identified and we know at least somewhat better what that is capturing, where the genetics, it's not capturing genetic risk, it's capturing correlated ancestry risk, which is, what does that mean? And that's that's challenging to me. And I guess the sample size issue and the crudeness, what has always fascinated
I'm
me.
sure that if we had much bigger sample sizes, and we will in some of our analyses, we are starting to.
Yeah.
I shouldn't say ours, I'm not participating myself very much anymore. But maybe, I'm sure that if you get a large enough sample size, you really see differences.
Well, that's where, the statisticians really come into place, because, one of the things that we've been sort of I don't recall the specific context. Oh, it's with the social determinants in the electronic health record. So they're doing this work. They've created a cohort of using the national, VA data. So it's like everybody in the VA.
Yes, a million VA.
And so it's kind of like, okay, well, you will find something that's significant just based on the sample size. And so what I've been really encouraging is, like, you need to have a statistician, and we do have a statistician on the team. He's like blessed it, and I'm like, great, but I still would say we're gonna draw a critique that whatever, because it's such a huge sample. That's that. All right, folks, I've gotten a text to tell me to get on my next call, so thank you very much.
Thank you very much.